Colon and rectal surgeons do, our main areas of expertise are in colon and rectal cancers, inflammatory conditions such as diverticulitis and Crohn's disease, ulcerative colitis. And then we do a fair amount of benign disease such as hemorrhoids, fissures, prolapse, incontinence, and all this pelvic floor stuff. So this is what I work on, the guts. The colon is this nice structure that functions mainly to remove the excess water from the stool when it comes out of the small bowel, which is depicted here. So all of these parts are important for our day-to-day function. So my job as relates to the pelvic floor is primarily in what we call this posterior compartment. So my territory is what's outlined here in the dotted lines. The symptoms that I generally get that are related to bowel health and the pelvic floor, and probably the things that people complain most bitterly about, are gas and bloating, organ prolapse, rectal prolapse or hemorrhoidal prolapse, incontinence, and constipation. There are many ways to deal with these conditions non-surgically. A lot of the gas that we pass is actually gas that we swallow. We swallow air all the time during the day as we talk, as we chew gum, as we drink carbonated beverages, and we burp a lot of that up, but a fair amount of it goes south too. Other things you can do for yourself to decrease the amount of gas that your body produces is to avoid this acronym, SAD gas: soy, artificial sweeteners, dairy, gluten, alcohol, sugar. Incontinence is a big topic every day in my office. One of the most important things we can do here is modify our diets. In many young women who have an episiotomy or a tear with childbirth, we can repair the sphincter muscle and they have significant improvement. This is how we do this. We essentially make an incision here. We identify the scarred area and the ends of the muscle, bring them out here. We overlap them and sew them together. So as you can see, you convert this little U to sort of a modified Y so that you have more length between the anus and vagina. So rectal prolapse. This is, as Dr. Shah mentioned, this is more of a lifestyle and a comfort issue. Very few people ever died of rectal prolapse, but it sure is uncomfortable, and everyone knows your rectum just doesn't belong outside your body. So in rectal prolapse, the rectum gets pushed to the outside, and you can see it unfolds sort of like a tube sock, and you have this double thickness of bowel here that comes out. With pelvic floor physical therapy, we can actually improve this. And with short segment rectal prolapse, we may find that when we retrain the muscles of the pelvic floor with physical therapy, and that patients are no longer straining so much to have a bowel movement, the rectal prolapse may not become an issue.